I would just like to say thank you to Kidney Cancer Canada. You are part, for all of you who are here today, you are part of an extraordinary organization. To see the success that this group has enjoyed over the last 5 years, started by 2 patients who were motivated to make a difference for themselves, but more importantly for others. And over a very short period of time to now be in a position where they're talking about funding research programs, hosting these kinds of educational events for patients with kidney cancer, and the endless hours that go into supporting and trying to reach out to new patients and to patients who are dealing with this disease. It's hard to identify in the cancer world another organization that has been this effective and successful. And so my hat is off to all of you who are involved, particularly to Deb Maskins, and I'd also like to take a moment to remember Tony Clark, who was the other director who is no longer with us. There's some information in your package about Tony and about a research fellowship for nursing. That is named in his honor, and that is so fitting, so appropriate. So thank you. I now have the opportunity to talk to you about current medical treatments for kidney cancer. And I'm going to start by using that term a little more broadly. Sometimes when people talk about medical treatment, they're talking about treatment that is non-surgical. So drug treatments, surgical treatments, drug treatments, radiotherapy treatments. I like to think of medical treatment in the context of what can we bring to the care of a patient that encompasses all the expertise that can make a difference for that patient. Start with a question. What is the optimal state-of-the-art therapy for a patient with kidney cancer? And I think the answer to that question is that the optimal treatment for a patient with kidney cancer, and this is true for patients with any type of cancer, combines the best that we can bring to bear in that patient's care in combining surgery, non-surgical treatments, which can include drug therapies, radiation treatments, supportive care. That's the best option for a patient with treatment. And our challenge in providing care is to provide an integrated, seamless approach to these problems. It is true that the primary treatment of kidney cancer is surgical management, and that has potentially a role to play in patients with any stage of kidney cancer. But as we've learned in many other types of cancer, we can bring to bear to the treatment of a patient who's had surgery for their disease other treatments that may have an impact on their potential for the disease to come back. And if the disease does recur after surgery, then we can bring these other tools to bear and try to help manage patients that are dealing with the effects of advanced kidney cancer. And so the first question I think that always has to be asked and answered in dealing with a new diagnosis of kidney cancer is this patient's tumor amenable to surgical removal? Now, I'm not going to spend a lot of time talking about surgery because you're going to hear from Dr. Drakenberg later, who is a uro-oncologist, and he'll give you more of the details about the surgical approach. But from an oncologist's perspective, a medical oncologist's perspective, one of the exciting things I've seen over the last few years is the attempts on the part of our surgical colleagues to save functioning kidney. And where we used to remove the whole kidney along with the tumor, we're now looking at the option, which is viable for many patients, of removing only the portion of the kidney which is diseased and leaving intact kidney function in place. If the tumor can't be removed, is it possible to do something to try and destroy the tumor with some form of ablation procedure, we call them? And can this be done in a way that gives us the maximum control of the disease, but also allows us to preserve as much normal kidney function as possible? And that has been a very exciting development in the treatment of kidney cancer in the last few years. So now I'm going to branch off a little bit. And so what do we mean when we say medical treatment? Well, traditionally what people are talking about is non-surgical forms of treatment. So drug therapies, radiation therapy, supportive care. And primarily today, these treatments are used in managing kidney cancer that where surgery does not necessarily have a role to play, or where the surgical options for management of that patient's disease have been exhausted. The treatment of this disease has changed dramatically in the last 10 years. There was a point in time where, for me, it was very distressing to be going down to the clinic to see a patient with a new diagnosis of kidney cancer, because I didn't have a lot of good news to give that patient in terms of what we had to offer them. And that has changed significantly over the last 10 years. And those changes have come because of our ability to bring multidisciplinary care to the table, but also because of clinical research. So I'm going to talk a little bit about some of the drug therapies that are available to patients now. We can use the term chemotherapy, although we don't tend to apply that term to these drugs. Chemotherapy simply means drug treatment. People have this idea that chemotherapy refers only to treatments that are used for cancer. It simply means drug treatment. So these could be thought of as a form of chemotherapy for kidney cancer, although they are not necessarily, in patients' minds, approached the same way, because I think a lot of people tend to think of chemotherapy treatments as you go into the cancer clinic and somebody puts an intravenous in your arm and you get a treatment, you go home afterwards and you throw up for 2 days and lose your hair, and that's chemotherapy. Anyone in the room who's had the challenge of dealing with these treatments will know that the side effects are different than what we think of attached to standard chemotherapy treatments, but they're certainly no less challenging to deal with. They have the advantage of being orally administered agents, which is a big plus for patients. So the first class of drugs is a group of drugs called tyrosine kinase inhibitors. There's another group of drugs called mTOR inhibitors that we'll talk a little bit about. And then there may still be a role in some sets of circumstances for what we call immunotherapy. That is an older form of treatment that is not used nearly as often today with the advent of the newer treatments with tyrosine kinase inhibitors and mTOR inhibitors. So let's talk a little bit first about the tyrosine kinase inhibitors. Well, what are tyrosine kinase inhibitors? Have to ask the question first. What are we inhibiting? What is tyrosine kinase, and what do these proteins do? Tyrosine kinases are cellular messengers, and they function in a number of important processes, both in normal and in cancerous cells. They are important in the processes that are involved in division of cells, again, both normal and cancer cells. They are important in a process called apoptosis, or what is referred to as programmed cell death. All cells have a life cycle that includes birth, growth, division, death. In cancer, that mechanism and those messages are often skewed, and so cells that are supposed to die don't know how to do that. And that can be one of the challenges we deal with in managing a cancer. The other process that is important when cancer spreads to another part of the body is what we call angiogenesis. So when cancer cells migrate to other parts of the body, as they start out as a single cell, they can grow and divide into small deposits of cells that can survive because they can draw from the environment around them the nutrients and the oxygen that they need to grow. But once that deposit of cells reaches a certain size, it needs to develop a blood supply in order to ensure that it has access to those nutrients and oxygen. And that's called angiogenesis. And some of these tyrosine kinases are part of the cellular messages that cancer cells start to produce when a deposit of cells reaches a certain size and says, okay, if we're going to get bigger, we got to ensure our blood supply and our access to nutrients. So they send out these signals that result in blood vessel formation to supply that tumor deposit. And these agents then not only act on the tumor cells and affecting tyrosine kinases that are functional within the tumor cells, but they can also have an impact on this process that results in blood vessel formation. And there are other processes that they also impact. So, years ago, tyrosine kinases were recognized as a potential target for the treatment of cancer. And these agents are being used and are actively being researched not only in kidney cancer, but in many other types of cancer where they are also having a significant impact. So they are a class of drugs that target tyrosine kinases and affect the functions of these protein messengers. And here's a list of some of them. Most of you will be familiar with some of these names. Sunitinib or Sutent is the agent that we have probably been using the longest in the treatment of this disease. Sorafenib is another agent. These are all tyrosine kinase inhibitors. They have a lot of similarities in the way they act, but they also have slight differences. So they're not all the same. And that's, I think, one of the things that's very exciting about this class of agents is that I think there will come a point in time where we are able to look at our patient and decide based on their disease, but also potentially on other issues that are a factor in their health. So if a patient has problems with their heart or has a history of diabetes or other problems that might say to us, you know what, in this list, I think this is probably the best agent to use in your sort of circumstances because I think it's going to help to manage your cancer, but it's also not going to cause us problems in dealing with these other health issues that we need to pay attention to. We can't just treat the cancer. We have to treat the patient and along with all of the problems that that patient is also dealing with potentially along with their cancer. So there's a list here of 3 agents which are potentially available and in use in the clinical setting now for the treatment of kidney cancer. There are others like Axitinib, which are coming down the pipeline. There's another agent called TKI-258, and there are many others in clinical trials. There are over 400 of these types of drugs in various stages of clinical research and clinical development, many of which I think will have a role to play in kidney cancer. So they are currently recommended for the treatment of advanced kidney cancer, patients whose disease is no longer amenable to surgery or where we can't remove all of the sites of disease that are affecting a patient. And these drugs have significantly improved the outcomes for patients with advanced kidney cancer in the last few years. It has been incredibly gratifying and exciting to be involved in some of the clinical research trials that have brought these drugs to bear in the clinic. And I have patients who are alive today and doing as well as they are because of their potential to be involved in these clinical research trials. So one of the take-home messages I want you to take from my talk today is that the best medical treatment for a patient with kidney cancer also includes access to clinical trials. That's one of the most important things I think we can be doing in the oncology world to improve outcomes for our patients, is making those available. They're orally administered, so they have that convenience for the patient. They provide benefit to the majority of patients who are treated with them, and we can measure those benefits in various ways. Either shrinkage or stabilization of a patient's disease. They can delay the progression of metastatic disease. And they can help us to manage the problems, the symptoms that a patient's disease is causing for them and improve their quality of life. And they can help us to help patients to live longer with their cancer. And there's a growing body of evidence that is suggesting that if you use one tyrosine kinase inhibitor and that drug stops working, or potentially that drug is not one that's well tolerated by the patient, you may be able to get benefit by switching to an alternative tyrosine kinase inhibitor. These are very potent drugs, and anybody in this room who's been on them doesn't need me to tell them that. They have to be administered in a setting where physicians are very comfortable and familiar with their use and with the side effects of these drugs. If patients are going to benefit from these treatments, we need to be able to keep them on these agents. And one of the challenges there can be managing the side effects of these drugs. Things we hear about from patients who are on these. The fatigue is a big problem. It can cause problems with a sore mouth, affect your sense of taste, and cause diarrhea, abdominal pain. These are all things that patients have to deal with on a day-to-day basis. Not all patients get all side effects, but there's a long list of potential problems in taking these drugs. It can affect the skin and cause a rash on the hands and feet, and painful hands and feet. It can affect your blood pressure, so it's very important that we're monitoring that and intervening appropriately if blood pressure becomes a concern. They can affect the thyroid function and the heart's function over a long period of time, so that also needs to be monitored. So those are the tyrosine kinase inhibitors, and that is, as I said, an extremely exciting group of drugs that are having an impact on many types of cancer, kidney cancer being a very good example. So we'll talk a little bit about another class of drugs now called mTOR inhibitors. So again, what the question is, what is mTOR kinase and what does it do? So this is another cellular messenger that plays a role in many of those same processes: cell proliferation, differentiation, apoptosis, which was that programmed cell death we talked about, and the formation of new blood vessels that supports the growth of tumors when they spread to other parts of the body. So this is therefore another potential target for the treatment of many types of cancer. And so mTOR inhibitors are a class of drugs that affect mTOR and its functions. There's a list here of 2 agents which are presently approved for use in kidney cancer: Temsirolimus and Everolimus. So many of you may be familiar with those names. And there are many others in development, similar to the tyrosine kinase inhibitors. Temsirolimus does have to be given by intravenous administration. It is given on a weekly basis, so that is inconvenient for patients. Everolimus is administered orally, so has that convenience. Again, these are agents which can provide benefit to patients with kidney cancer that has spread to other parts of the body, and in what we would call first-line therapy, so a patient's first exposure to drug treatment for kidney cancer, but also if a patient has been treated with a tyrosine kinase inhibitor and their disease is no longer responding to that treatment, mTOR inhibitors have been shown to provide added benefit. So we have the option of being able to switch to an agent that acts by a different mechanism, which in some cases, in some ways, you would think makes sense. If the initial mechanism that we attacked wasn't responsive, let's see if we can go at it another way. Temsirolimus, that is administered intravenously, has the potential to benefit patients who often have the most aggressive and the most aggressive form of disease and the worst prognosis in terms of how their disease may potentially behave in the first-line setting. It does need to be administered intravenously, but it is generally a well-tolerated drug. Everolimus, the oral agent, can provide benefits to patients whose disease is no longer responding to a tyrosine kinase inhibitor. But again, we're talking about a group of drugs, very powerful with potential side effects, and they do need to be used and monitored in a setting where patients can be appropriately followed, and these side effects can be managed so we can keep patients on these treatments. Mouth sores, fatigue, a rash, and a problem with inflammation in the lungs that can affect, cause problems with shortness of breath, cough. A rare problem, but when it happens, potentially a very serious one, so we do need to monitor patients for this very closely. Now, I've included this in the list. It isn't a treatment that we use very much anymore in Canada. Before we had access to the Tyrosine Kinase Inhibitors and the mTOR inhibitors, there was a type of treatment that we refer to as Immunotherapy. And there are two drugs that patients may recognize the names of these if you've done any reading, Interferon and Interleukin 2. As I said, older forms of chemotherapy, there may still be a situation where that is worth considering, potentially, although I have to say I haven't used this type of treatment for several years now because of the availability of other treatments that I think are more effective. What these are thought to do is to stimulate the patient's immune system to recognize and attack the cancer. And so this may be something that in the course of managing your disease, your doctors may talk to you about at some point in time along your cancer journey. There are other things that we can do to help manage cancer and sometimes there are situations where drug treatments may not be the most effective way to manage that problem, and one example of that is radiation treatment. In your package, you'll see an article that speaks to treatment with what's called the gamma knife. That's a form of focused radiation. Radiation treatments can be delivered in a number of different ways. And basically what we're talking about is using high-energy X-rays to treat cancer. It's not a curative treatment, but it can be a very effective adjunctive treatment to surgery, to chemotherapy treatments in help managing particular problems, particularly if disease is affecting bone, where that causes pain. Radiation treatment can be very effective in managing that. If disease is affecting the lungs and that's causing pain, bleeding, or coughing, radiation treatment can be very helpful for that. And sometimes when this disease affects the brain, radiation treatment has a very important role to play there. So, again, I think the most important message that I would like you to take away from today is that the management of kidney cancer over the last 10 years has significantly improved, and for those of us who work in this area, we see the potential for many more exciting things coming down the pipeline that are going to have a significant impact on what we can offer to our patients. And the best outcomes for patients are achieved when we can bring to the table the skill of the surgeon, the radiation oncologist, the medical oncologist, and the expertise that they bring to the table in applying their skills. Clinical trials are key to being able to bring these kinds of benefits to patients early, and that's what leads to us being able to bring these treatments into day-to-day care.